Okay, we're looking at a right lateral, left lateral, left lateral, right lateral, huge right rotation with significant degeneration, and a left lateral translation. We're looking at the knees. We're looking at an abnormal patellar tracking here. And if we had a patella here that we could monitor, we'd see it abnormal as well. So we're going to distract this, cause inflammation. Looking at the lateral lumbar, we're looking at significant abnormal bony deterioration, consistent with diffuse idiopathic hyperostosis or DISH. Now this, we still have mobility here because when we look on the front aspect, bending off to one side, there is still mobility. There's a significant osteophyte formation, but by gosh, it still bends. So we can get a correction. So we're going to start off in abdominal suspension. We're going to vibrate on the left concavity there, and we're going to get him working. Okay, so start off abdominal suspension. This is cervical challenge. Go up to the occiput. There's an increased tone on the right. I'm going to support on the left and challenge in the anterior to posterior direction on the right. Coming back down here. There's actually a significant change. So I'm going to take it as a right anterior C1. That's a cervical challenge. Now, I'm going to work the tissue on the left concavity while palpating the convexity until there's a change in the intrinsic muscle tone. Now, knowing that the knee has been off for a while, I'm going to distract and laterally flex, checking on each segment of the lumbar how the intrinsic muscles of the spine are firing. The left side is actually moving fairly correctly, the right side is not. On lateral flexion, the right side is increasing in tone, indicating an abhorrent firing of the intrinsic muscles. So we need to change the proprioceptive influence. So we're going to vibrate over the joint mechanoreceptors in that area because it could be an abnormal firing from either side. Either the facet joints or the intrinsic muscles, which are also proprioceptive. So distract and laterally flex. I still have the abhorrent firing, so I need to reposition or re-stimulate those receptors. That's working better. Once we restored normal proprioceptive response, and we can cause a deep inflammatory response. And as an asymmetrical firing here, typically, and it does correspond with the x-rays, that the right side, or the convexity in this area, is spasming out to increase the tone. So I'm working the tissue on the inside portion of the curve, or the contralateral side of the muscle spasm. Muscle spasm is on the convexity, correcting the problem. So now distracting, creating negative force loading on the left side. Good, that's working. So now I'm going to set the drop table. I'm going to crank it up for an archaeologist. They're thicker than the average person. Good chiropractors and archaeologists. We have the same body, my friend.
It's kind of a sphinx, right?
That's what I was thinking. It's unique in the culture of humans. So now this is causing a deep inflammatory response at the level of the disc, initiating cell production. Change that diffuse idiopathic skeletal hyperostosis. Restore normal tissue production. Now there still is an increased tone on that right. Now this is very gentle, but we have to cause an inflammatory process in that area. Good, right there, until the muscles start to equalize in tone. Then that means we've changed how the muscles are firing. Knee to this side up, my brother. This one? Yeah, face me. Now, knowing that there's an autoimmune condition going, and apply pressure on the sacrum to get the parasympathetic nervous system working right, you won't fall. Now go way over on the other side.
All right. That's like almost.
A warm summer breeze. I know, it's hard to even know I'm adjusting yet.
Right.
Is that what you were searching for?
Yeah. I'm used to.
This is an anterior C1, so it's very gentle. Now the intrinsic muscles didn't totally release, so I'm going to go superior to inferior as well. Okay, now this one's right over that right side area. We're going to move them alive. You're not going to fall, my friend. I got you. I haven't dropped anyone yet this morning. And again, it's early. Usually drop 2 or 3 by 7. Good. Go right in her back. Continue to drop, and you'll see on the side posture there's no rotation in the spine. Drop until you feel a change in the intrinsic muscles. Now he has a significant right rotation at the base of the cervical spine, top of the thoracic area. First, I'm going to check the skull plates. If the skull plates are misaligned, the brain can't get the appropriate nutrients.
Some kind of elevation in this.
I know.
That's why all my wisdom, archaeological wisdom, it's called cranial bump. Buddhist word, Shisha.
There is. They actually call this the bump of knowledge right there. They really do. Honest to God. I know. I hate it when he's right. And you see almost no rotation of the head. Just very, very gentle. Now this is the top of the thoracic area. These are the nerves that supply the heart. So you'll see it's a spinous push, but again, no rotation. Just a nice, gentle impulse. Okay, now, cross your arms. So now this is going to be lower left, a few of them on the right, where the most bony growth is, and the upper left. I'm going to do the lifting. Let me lift you. I know. That'll make you change your religion. I don't have one. I know you're going to say that. So now we got to work the interosseous membrane in the tibia and fibula. Yeah. We got to restore normal dorsiflexion in order to get some blood flow to reverse the degenerative process.
Great job.
Now, we're going to distract the knee joint. Now, using a significant force, then a slight bend. Now the medial meniscus is going to be exquisitely tender, but by causing a brief inflammatory response here, it's going to initiate cell production. So right here, that's the joint distracting. And sure enough, there is still movement. So by causing the consistent distractive force, then the cells will respond by regenerating. Now, since he's got an altered gait on one, that's going to change the force loading on the other. So again, medial meniscus. Just to reposition it slightly in order to change the biomechanics. Then you go, rise, my brother. It's ready for the world.
You think so?